Hello, everyone. I'm Dr. Catherine Kennard, the IDPH Preventive Medicine Medical Advisor, and I am delighted to welcome you to the first Fast Facts webinar of 2026, Cannabis as Medicine, What Every Clinician Should Know. I am thrilled to have with us today Dr. Leslie Mendoza Temple, who is board certified in both family medicine and integrative medicine. She has affiliations with Endeavor Health and also the University of Chicago, and is the chair of the IDPH Medical Cannabis Advisory Board. We also are happy to have with us Jeanette Candido, who is the IDPH chief of the Division of Medical Cannabis. I want to mention, of course, as you hear us every month, that IDPH is authorized to offer formal continuing medical education, and we follow all applicable laws to make sure that it is meeting the set criteria for CME. If you're not a physician, you will need to check with your licensing organization to determine if CME credit is applicable for you. We have no financial conflicts of interest. And just a little housekeeping that these webinar sessions are recorded and will be shared with all participants. If you want to ask a question, there's 3 dots at the bottom of your screen down here. It's not very easy to see on this slide, but you can click on that and then put in your questions, and we will make sure to get to all of them. After this webinar, there will be a survey sent that it has the continuing medical education questions, and you will need to complete that within 7 days in order to get credit for this webinar. All right, so with that, I'm going to just move ahead with a quick little review about evaluating the scientific evidence to kind of set up Dr. Mendoza Temple's presentation. Why do we care about making sure that a journal article or a study we're reading is credible? Because we want to know whether it's real and whether it's applicable to our practice when we're seeing patients or to any public health decisions that we might be making. And what we look for is bias, because bias in a study, and every study is going to have some bias, but we try to find studies that minimize the bias because bias will affect the results. And what the results that come from a study that has significant bias may not be true. So it's hard for us to base decisions on that. And bias can happen at any point in a research project, from design through implementation all the way up to publication. So it's just important to have some skill at being able to look at journal articles, published studies, and try to determine whether or not it's a correct and valid study before we make decisions that might impact patients on that. Review for all of you, I'm sure, hierarchy of clinical evidence. Just wanted to touch base on this, but it's from the highest level of evidence is clinical practice guidelines, meta-analyses or systematic reviews, and randomized controlled trials. That's where we have a systematic way of producing the study that will minimize bias. And there are studies that are more likely because of how, but still valid, and especially if there are multiple studies that are cohorts, case control, and so forth, they are considered more likely to have bias just because of the way they have to be conducted. A lot of public health studies are in these what we consider observational studies. And then expert opinions, like from someone like me or yourselves, editorials, those are important, especially if a person has a lot of expertise, but that's considered to be the lowest level, the lowest strength hierarchical in the hierarchy of clinical evidence, because it's more likely to have bias than these other more systematic evaluations. And again, this is just based on bias and how confident we can be that what we're reading is valid and true. So there's just a few ways you can go about doing this. The first is make sure you're reading reputable journals. So anything that's published on the databases such as PubMed or the Directory of Open Access Journals, those have stringent reviews and stringent review processes to make sure that they're publishing or listing credible journals. And then once you have the journal, check and see if they say that they comply with ethical standards, like those published and developed by the Committee on Publication and Ethics, or COPE. Also, make sure that you're looking at journals that are peer reviewed. And you can consider one factor to look at is the journal impact factor, or how often articles in that journal are being referenced by or cited by other scientists. So very generally, if you go to the web page for the journal, if it's a journal you're not very familiar with, you can it should have a GIF factor listed or some other comparable measure. There's a couple of them, but basically a GIF greater than 1 or is a minimum. And then while 3 or higher is considered good and greater than 10 is excellent. Just as an extreme outlier, the New England Journal of Medicine has a GIF factor of 96. So essentially, most of the articles in that journal are cited at least 100 times. Don't want to spend a lot of time on open access. I know we've all seen there's been a real increase in the number of journal articles that are published online, open access and free, which is important because it makes that information more readily available to people, but it also doesn't often have the same stringent controls that you find in an actual published journal. It depends. JAMA, the Journal of the American Medical Association, has several online free publications, and those you could be confident are going to be high quality. So just some things to think about when you're looking at open access. Again, you should look and see one is who is publishing in this journal? Who are the authors? Is there an editorial board? Is the journal something that's kind of cohesive, or are they publishing all over the map, completely unrelated disciplines? Are they asking for a fee and then they publish based on a fee? And do they provide peer review? Who are the peer reviewers? Do they seem like people who would be knowledgeable about that topic? So those are some of the things that you should look at. Also, the author. Look at the authors. Do they have expertise? I look up at the authors and see who they are. It helps establish the validity of their research. And if they're affiliated with a major academic institution, you can be assured that there are going to be protocols in place at that institution that ensure that research is conducted ethically and the results are valid. Just 2 more slides here. One is when you get the study, of course, taking a look at it. Is it older, more than 5 years old? And what you're looking for may no longer be relevant. Is there a comparison group? That's often very important, because if they don't have a comparison group who didn't get the treatment, cannabis for say, it's kind of maybe hard to determine whether or not the results, whatever they were actually related to the treatment. Size of the study. If it's really small, it may not be able to show statistically that there's a difference between the intervention treatment, for instance, with cannabis, and the comparison, no treatment group. So you have to be careful about really small studies, and that may not be generalizable to the rest of the population. And then they should always talk about what the harms were, potential benefits, and the limitations. And when you're reading it, does it seem to you like their conclusions logically follow from the results that they received? And finally, one study is one study. So you can't base everything on that one study, and it should be considered in the context of the findings from similar studies. But I do want to add this caveat that because cannabis research has been highly restricted in this country, clinical studies for conditions being considered for inclusion, for instance, in the IDPH medical cannabis patient program, which we always look for, may not exist. And then what we've just been talking about is one aspect of what we look at when we're making determinations, which Dr. Mendoza-Temple will speak to you about in just a moment. But it's the lived experience and preferences of people with debilitating conditions. Those must also be considered. And that's all I have, and I will step back here and turn it over to Dr. Mendoza-Temple. Thank you.
Great. Thank you for that. And can you see my slides okay, Dr. Quinard and all? So just a little background on my experience. I have no disclosures, but When I was chair of the Medical Cannabis Advisory Board in 2014, and then again, most recently, the medical cannabis, the list of conditions for that IDPH accepted for medical cannabis certification what was an inherited list that already had about 30 conditions already on there, not determined by IDPH or any advisory board. And then moving from there, there were conditions that have been added since. And something to keep in mind when we look at that list, we as a board were charged to, it was used to be called the Medical Cannabis Compassionate Patient Program. It was, we didn't have evidence to go on in order to add conditions to this. So it's been a kind of a messy thing where we have the policy and sentiment and other things and the individual patient going ahead of the science. So now we're sitting here kind of backtracking, going, okay, what is the evidence base behind these conditions, and not finding enough. So I wanted just whatever side of evidence you need, whatever level you need as a clinician to go ahead and try a new therapy. Everyone has a different threshold. But cannabis is here. Your patients are using it, your neighbors are using it. It is incumbent upon the healthcare professionals to learn as much as we can about it. And then the evidence base needs to catch up. So thank you for that introduction, Dr. Quinard, on really the best way to evaluate this. But my objectives here to talk about what is the current evidence base on the therapeutic use of cannabinoids, mostly with respect to pain, to compare and patient success and pitfall cases, especially with the risks and downsides of cannabis, talk about challenges that are coming to us as clinicians, and how do you advise patients, and what about the medical cannabis supply chain? There's all kinds of issues there. And to very brief summary of regulatory updates regarding cannabis. But why is all of this important is because a majority of Americans live in a state where marijuana is legal, either recreationally or medical, and in states where it's not legal, easy to obtain. So you can pretty much assume that more than 74% of Americans are exposed to it or are eligible for it. So keep that in mind. And as things keep changing with cannabis going to Schedule III, this is an ever-changing dialogue, and I am having trouble keeping up myself. But you need to know it, whether you're in a legal state or not, all about cannabis. So as a brief review, we all have this. Mammals have an endogenous endocannabinoid system that helps us live, survive by relaxing, knowing when to eat and drive our appetite, when to sleep and to maintain quality sleep, to protect ourselves from infections. It has functions in immune areas of our bodies, to forget pain, to forget stress, so that we can be more balanced emotionally, but it has downsides, of course. And so with those 5 functions, this helps us in our homeostasis to just do our day-to-day thing. We don't always need to be hungry. We don't always need to sleep, but our endocannabinoid system knows our moment-to-moment needs. And we make our own endogenous homemade cannabinoids to make these things happen. Then you have the outside world of cannabinoids, for instance, THC from the plant, that also affect our endocannabinoid system. And this is where we are looking to use this as a potential therapeutic target, but we will talk about the ups and downsides of that, as with any drug. And so the endocannabinoid system has receptors all over the body. They're everywhere, particularly CB1 in the brain and CB2 in the immune system. And this is something we just need to acknowledge exists, and think about the level of the medical student, that we don't have to know every single nuance of the ECS system, but to understand how it interplays with the opioid system and the other parasympathetic nervous system, sympathetic nervous system. They have so much play with each other, and the cannabinoids impact almost every aspect of the human body. So having that understanding is key, and it needs to be discussed in medical school. And by the way, JAMA Open Network just published mine and my research group's article on a expert consensus on what medical students should be taught in medical school. And that came out October 7th, just last year. We're thrilled to have a set of principles that can be used to derive curriculum. And then on February 2nd, the Cannabis Research Institute through the University of Illinois, we will be discussing how do you actually teach this in medical school in a very crowded curriculum. More to come on that. So how does cannabis work on pain in the brain? Since pain is my focus today, and this is super simplified. I'm a family medicine physician, so I'm not a neuroanatomist, and so I know I'm missing parts of this, but it can work on down regulating the ACC, the anterior cingulate cortex, the dorsolateral prefrontal cortex, and help promote parasympathetic activity, which is the rest and digest side of our nervous system. There are functional MRI studies on this. There are ways to see what cannabis does, and we do this with other things such as meditation, breathing exercises. The field of mind-body medicine is really exciting because they are really studying objectively how do these nebulous, vague kinds of therapies work on the brain, and you can check functional MRIs, and you can check cortisol levels and other aspects of human function. So these are some proposed mechanisms of how cannabis may work in a chronic neuropathic pain system. So brain connectivity, you saw me talk about CB1 receptors being very prevalent in the brain and cannabinoids affecting that. So that's my very brief ECS 101. From an evidence standpoint, this is already old stuff. This was published in 2017 by the National Academy of Science on the health effects of cannabis and cannabinoids. And it's a very neatly packaged evidence base. And this to me was just really useful. We know a lot about cannabis's downsides with abuse, dependence, car crashes, teen use. We know plenty, thanks to the National Institute for Drug Abuse. But what about the health effects, which you hear all over social media, and your patients are telling you, hey, I want to use this for my chronic pain. So this board came together. This is your government tax money paying for this, and it's available free online to you. I put the link here, and I'm going to summarize the top levels of evidence here, but just Google National Academy of Science cannabinoids, and you'll see this. And it's a very lengthy document that you can just look up online. And they grouped the evidence base based on expert consensus of what was available at the time. So of course, we would love gold standard randomized controlled trials and all of that, but it's very difficult, as Dr. Cunard said, to study given a historical basic chokehold on research, meaningful research that we can do on cannabis, because it's too hard to get. It's too hard, you could waste your entire adult life as a researcher waiting to get through the paperwork to study cannabis in an RCT. That hopefully is going to change very soon with the rescheduling. So the highest level of evidence here that we see from NAS, conclusive or substantial evidence that cannabis can be effective is a treatment of chronic pain in adults. And this is like a really big statement. As an antiemetic in chemotherapy-induced nausea and vomiting, and for improved patient reported MS spasticity. Now the cannabis for antiemesis and the MS spasticity was done with the pharmaceutically sourced cannabinoids. And it's not like all cannabis that you find in any dispensary anywhere is going to help with all of this. So you have to go with what they used in the studies. It's tricky because access to that is not available to everyone, but it's been a very good start to see this. And this is a very strong statement coming out in 2017. When I was chair of Medical Cannabis Advisory Board in the first round, we had a proposal to add chronic pain to the list of eligible conditions in Illinois. And this was a big part of that because to, get multiple conditions like osteoarthritis and rheumatoid arthritis and anything that caused chronic pain was getting to be very cumbersome. And there's no real good evidence for every single pain causing condition there was. So this was a practical way to go about adding this to the program, but of course it can be fraught with issues. And then less impressive, but yet moderate evidence that cannabis can be effective was for short-term sleep outcomes in those with sleep issues from OSA, sleep apnea, fibromyalgia, the chronic pain, and MS. So again, 2017, hopefully we'll be seeing more research coming out, and so many things are mixed about this. And then that there was limited evidence at the time for multiple conditions I have listed here: HIV, AIDS, wasting, MS spasticity, clinician measured MS spasticity, not patient measured, Tourette's, anxiety, particularly public speaking and social anxiety, and for PTSD. So again, old stuff here. They should do an update. I would love for the NAS to do an update on this. They should be commissioned to do that. So I looked at what's been done since 2017 that's relevant to this work here. And most recently, this came out in JAMA November 26, literally 2 months ago, that the summary conclusion that from randomized controlled trials, they do not support the use of cannabis or cannabinoids for most conditions where it's promoted, such as acute pain and insomnia. Now, I have to say, if you're a clinician that says, I'm done, no more, okay, cannabis doesn't work, spit spot, okay, there it is, that's my gold standard journal, I will say you're making a mistake in terms of being very limited in knowing really what other evidence there is out there. Because remember, I just said we can't do randomized clinical trials. So of course, the evidence is going to be low. But you have a patient in front of you with tons of pain, and I'll present a case where you have no other, there really are no other treatment options. You're going to let your patient sit there wallowing in their pain and say, I'm sorry, JAMA says cannabis doesn't work, and they're just going to leave your office and go somewhere else. So it's incumbent upon us to still consider this. But remember, RCTs they are not there. So of course, this is going to be a very accurate statement. But I did find randomized controlled trials, and I do need to look at whether they examine these trials and whether they were the highest quality randomized controlled trials. That's a very good evidence base right there. And I thought that came from good journals, good data behind that and methods. And I don't know why, but maybe it just wasn't enough to meet muster. But compared to placebo, they found cannabinoids provided significant relief from chronic pain, 33% versus 15% by the visual analog scale in the studies I'm going to show you briefly. And that minimal to no side effects were recorded. And of course, we know cannabis has side effects and has all kinds of downsides too. But in the trials, they didn't see anything that was meriting like moderate or severe types of side effects. So, okay, we are supposed to choose the least harmful approach, try to do no harm. Patients in pain, what are you going to do? So these were the 5 trials that I found, most of them done in Israel because they don't have restrictions on cannabis research, and that's where the cannabinoid system, ECS, actually was discovered. So they are the front runners in research. And my colleagues from the JAMA article on education competencies, they're from Israel and reached out to me to do the work we did. But in Wiseman et al. 2018, THC oil sublingual versus placebo, they found that neuropathic pain improved in their cohort. And I took the liberty of putting the dose there because, okay, what did they use? I have it listed there. For an average 70 kilogram person, they used 14 mgs of THC, which to me is very high. So, my beginner patients are using 2.5, 5 milligrams. You have to be very careful with, a 14 milligram dose. So in reality, would you do that with a patient? You'd never do that with a naive patient because they're going to feel really intoxicated. So we have to keep that in mind, that group, maybe they needed more also neuropathies, really difficult to treat. In Zhu et al., they used a different formula, just CBD oil versus placebo on the skin. And they found that helped neuropathy. To me, I'd rather go with that 4 times a day, just like you would with the topical NSAIDs, like diclofenac. you do have to put it on multiple times a day. And I do see patients think that that helps take the edge off. Might as well try it. Then we have the THC inhaler versus placebo. And they found that neuropathic pain improved versus placebo. Another study by Wiseman looked at THC oil sublingual versus placebo hemp oil, which has some cannabinoids in it, and that it also helped. Same dose at THC of 14 milligrams. So I have to look at how that's spread out, but still, you don't have to follow that dosing just because the study says use 14 milligrams. You will have phone calls, possibly an ER visit come out of that. And then with a Brazilian study, which is THC with CBD, which is more of a whole plant type of combo versus placebo, they found that fibromyalgia pain seemed to improve. So we see more in the neuropathy studies and then one for fibromyalgia. Is that a ton of evidence to convince you as a clinician that it helps with pain? Probably not, but we can't say there's no evidence. So now you know there is some. So here's a case it's a fictitious case, but one that I've put together for my other patients together. 75-year-old South Asian man with all kinds of heart issues, AFib, depression, diabetes, spinal stenosis, burning feet, on opioids, gabapentin, fluoxetine. We can already see issues here with the polypharmacy. Diltiazem, warfarin. Oh my gosh, he's on a blood thinner and an opioid and ACE inhibitor, aspirin, metformin. So there's many things we can do with this case, but he feels, no surprise, constipated, sleepy, and foggy-brained. And he's had 4 epidurals in 7 years and several rounds of PT, and he doesn't want surgery. Nobody wants to operate on him, and he's miserable. He's done the acupuncture. This is my wheelhouse. Acupuncture, chiropractic care, massage, the integrative holistic things, but it's too expensive. He can't keep going. It's temporary. It helps, but it's just not enough. And he's saying to you, I want to use marijuana. What do you think, doc? So we have to think about the drug interactions of concern and what regimen would you advise? So considering that he is on fluoxetine and it can impact your pharmacogenomic, your CYP2C19 inhibitor, increased CBD side effects can occur, maybe some sedation. Diltiazem, the blood pressure med, that's metabolized by CYP3A4, so that can make the cannabis feel stronger, whatever dose he took. And the CBD on Coumadin, warfarin, sorry, it's CYP2C9, the INR can go up, and so he can bleed more easily. And you don't want someone who's feeling woozy from cannabis falling and hitting their head and having a bleed. So many things to keep in mind. And of course, with gabapentin and Norco, you've got additive CNS depressant effects. He was already complaining of feeling groggy and sleepy, yet you're still like, no surgery, no. We can't just send him to psychiatry and just say, well, just sort it out in your head. No, you have to do something. And so if he's like, I really am motivated to try it, he's got help around the house, you could start with a microdose of 1.25 to 2.5 mg of THC. Any amount of CBD, we don't really know the magic doses there. And that's typically going to be 1/8 to 1/4 of a piece of a typical edible at bedtime. And then you could put a thin layer of a CBD THC 1-to-1 cream wherever it hurts. You could do it daily, or as you saw in the study, 4 times a day. And see if that takes the edge off. And it also lets the patient have some control over this, saying, it was my idea, I want to try it, and I find that it's helpful. So the take-home point is when you start someone on a cannabis who are cannabis naive or really inexperienced, you want to just cut that in 4 pieces. Never eat the whole piece your first try. And if that piece has 10 milligrams of THC in it, 1/4 of that will be 2.5 milligram, and only take 1 piece a day and titrate it up night by night. Nighttime's a good time to try these out, because any side effects, you probably, hopefully, are sleeping through it and maybe even sleeping better. When in doubt, I believe topicals are nearly always worth a try, but it depends on if you have skin sensitivities. And I know I'm running out of time, but here's something to keep in mind. And someone who's experienced with cannabis, they tolerate it well, but then you put them on Bactrim for a UTI and she starts to feel dizzy. And we can probably explain that from the CYP2C9 inhibition. The Bactrim made the cannabis more, it decreased its metabolism. So THC hung around, and it was like she took more cannabis than she usually did, hence got dizzy. So keeping that in mind, I'm going to skip over these real quick because I'm going to run out. With safety, we've got pitfalls with cardiovascular risk, cannabis hyperemesis syndrome, cannabis use disorder. And this one of your clues is hot showers make you feel better. You could even use topical hot pepper cream on your belly. Put gloves on when you do that. And by the time you've reached the ER, you may be getting some of these medications. And the throwing up, the vomiting is onset is over 6 months. We're seeing a lot of this happening in the emergency room. But be mindful that not every vomiting teenager is having CH. So we have to be careful. You still need to work them up. But that's something to consider. And the only treatment for that is cessation. You have to stop using cannabis. And then cannabis overuse syndrome, which is growing, is featured by this. This is the DSM-5 criteria, which these slides will be shared with you. And I'm not going to read all of that for you, but I'm now seeing a few of my medical patients coming through with this diagnosis. And now we have to talk about, all right, what else can we use for your symptoms? Then you have the man who says, I have fibromyalgia and PTSD and has a cannabis card and says, smoking joints are the only thing that works, but I'm queasy all the time and edibles don't work. So he's already said in his mind, I'm just going to smoke it. But what do I tell someone like this, who I've certified? I have a patient just like this. And I tell him this study. I tell him about the heart disease study showing that the cannabis users in the study had more issues with heart attack, stroke, and such. Keep in mind, though, this study did not separate out the edible people from the smoking people. 74% of the users in the study were smoking cannabis, and I think that has a lot to do with it. So we need another study that says, what about the edible only people? We're lumping all of cannabis together and then just pulling people off just because we're worried about they might have a heart attack or stroke. But what if you're like on a quarter edible every night and that's it, and you have really no other risk factors? So still, I don't panic when I see this. I tell my patients, don't smoke it as much. Try to smoke not at all, but you have to bargain, negotiate with these folks. So this is what helps my patients in a very non-judgmental way. And I have seen them cut down because they respect what I've said, because I'm not shaming them and making them feel bad about it. Okay, so of course, with kids, be careful with the edibles floating around. And we as practitioners have to be mindful of the labeling. This is a high THC product, hardly any CBD. Would you give this to a newbie patient? Absolutely not. This is flower, so they're going to smoke it. But this just gives you an idea of what's out there in the labels. Except with Illinois, the labels are much smaller. You need a magnifying glass for that. This is an idealized label. I'd love if labels looked like this. This would cost a lot of money to the industry, but this is what I want. I want to know the terpenes, flavonoids. I want to know all the other ingredients besides just THC and CBD content. Because maybe you could predict how this product might affect your patient with appropriate warning symbols. And this is the physician, Dr. David Nathan, who came up with all of this. So medical supply chains, I feel like we're seeing low THC products just becoming rarer, harder to find for patients as the recreational market has become the priority. We have to be really careful. So one way you can get around that is to DIY. You can take a solution of CBD hemp oil and then add a drop of pure THC, and now you can make your own 20-to-1 ratio of an oil. So you don't have to say that a dispensary doesn't have my 20-to-1. You can make your own. So that's just my way of getting around it. And my last thing is the proposal to change cannabis to Schedule 3. I don't know yet what this means, except we will, well, I do know what it means. It can open up more research avenues, but it doesn't change the way the current laws and, about medical cannabis or recreational cannabis is in the dispensaries. So we still need to follow all of those rules, but we may see more of the research that we need so desperately to prove or disprove the health claims. So I want to thank you for your time. This is my team. We've been together since 1999, and we see patients with chronic pain and other conditions that are very gravitating towards cannabis as treatments, which is where my interest in it came by necessity. So I will end there. Thank you.
Thank you very much. Dr. Mendoza Temple will be here. I just want to remind everyone to, if you have any questions, right next to the X at the bottom of the screen, there's 3 dots. You can click on there and put in any questions that you might have, and we'll have time for answering questions. Next up is Jeanette.
Hi, good afternoon. I'm with the Division of Medical Cannabis with IDPH. I will be talking about providing an overview of the IDPH Medical Cannabis Program, introduce our new system, and maybe provide some issues, discuss some issues that we encountered during participation in the program. As a background, cannabis in Illinois is overseen by 16 different agencies, but there are 3 primary cannabis regulating agencies. The Department of Financial and Professional Regulation regulates the dispensaries and, of course, healthcare professionals. The Department of Agriculture regulates the cultivation sites and the laboratories or the processing agencies that produce different types of cannabis products, and we regulate the patient program. A quick statistics: since the inception of the program, since it started in 2014, by the end of the last fiscal year, which is June 30th, 2025, the program has approved 281,621. And as of that date, we have 121,680 patients that are actively using the medical cannabis card, with about 16,000 caregivers. Currently, there are 21 medical cannabis cultivation centers, and out of 260 plus dispensaries, there are 55 medical cannabis dispensaries. So the difference between a medical cannabis and recreational cannabis is mainly the taxation. Medical cannabis is taxed at 1%. Meanwhile, recreational cannabis is taxed between 20 to 40%, depending on where you're purchasing the product. There are also different menus for medical and recreational use. And medical patients are permitted to grow up to 5 plants in their home. There are currently 56 qualifying conditions, so healthcare providers will be required to use our online system to issue a certification. They issue a certification, we do not consider it as a prescription, that the patient applying for the card has one of these conditions. We also have a process for petitioning to add to this list. In the last fiscal year, we added 4 additional conditions, which are highlighted in bold in the slide. What are the requirements for a healthcare provider to be able to participate in our program? You have to be currently licensed and in good standing in Illinois as either an MD, a physician's assistant, or a nurse practitioner. You have to have a current valid Illinois controlled substance license. You need to have a bona fide healthcare provider-patient relationship with the individual that you are certifying, and you need to be registered to use our online system. We do not accept paper submissions. So these are the types of qualifying patients that we have in our program. Adults are, of course, 18 years and over. Minors are under 18. Minors are required to have at least 1 caregiver. Both minors and adults may have up to 3 caregivers. Veterans may apply using their VA health record in lieu of an HCP certification if they were able to present their proof of active duty. We also have terminal applications are for those who have a life expectancy of 6 months or less. The patients and their caregivers are given 6-month card for free. We also have an opioid alternative patient program, which is a 3-month card for those who are prescribed opioids. How to to start with participation in our program. So we have a new system. Our new system required us to use an authenticator, which currently is Okta. So there are two-step process. First is to register with the authenticator by going through the illinois.sexdataportal.com/medical cannabis. Once you're there, there's a form, you just fill it in and then you submit. IDPH will do a quick credentialing review and then approve it. You will get an email that has a link, which is good for 7 days. That link will get you to the setup, which is step 2. It will set up your account with our system. After you fill it in again, and after you set up your account in our system, you go to ilpartner.illinois.gov to do certification and do all the activities in our system. So this new system integrates with other agency system. So it integrates with IDFPR for credentialing, Secretary of State for when they submitted proof of identity, Treasurer's Office. So the system, the patients pay directly to the Treasurer's Office. We do not handle the payment. And the seed to sale system that is used by the dispensaries and the cultivation sites. They also started a new system which is called Metric. These are the issues that we've seen during registration and setup. First is wrong link. HCPs used the wrong link and they ended up setting up a patient account instead of a partner account. So we have to correct that. They did not register with Okta, or for those who had previous accounts with our old system, and if they use a different email from the old system to the new system, that's another thing that we need to assist with. You have to call us to get all the assistance for all three. Another thing is because it's a system-to-system integration, the IDFPR data is very strict. So if your name does not match, what we're seeing is that like the first name field has the middle initial, and with the ID from the IDFPR data. So that's causing an error when they try to register. And of course, link expiration, it's more than 7 days. We will need to request Okta to send you an email again. And using DEA numbers. So we are required by law to use the Illinois Controlled Substance Number. So DEA number will probably gonna ask you, reject the application initially. Doing certifications and waivers. So each certification is good for 3 years, for up to 3 years. Extensions do not need new certifications if the card were not allowed to expire. You can also designate a condition as a lifelong, and you don't need to do new certifications, again, provided that the card did not expire. Terminal designation is for 6 months life expectancy, and it also is only a 6-month card, and it is non-renewable. For minors, it is required that there is a recommending and a reviewing healthcare provider. The recommending is the one that examined the minor, and reviewing healthcare provider, it could be someone who examined them or just reviewed the records. The only requirement is they have one of each and that the conditions match, so it will be accepted. For OAPP certifications, just need to show that the patient either has a prescription of opioid or a condition where opioid is commonly prescribed. For waivers, so each card comes with you have an allotment of 2.5 ounce every 14 days. If you as an HCP, in your professional opinion, it is not enough to alleviate the patient's symptoms, then you can submit a waiver to us. Some issues will be mismatched information. What you put in the certification and what the patient entered in their application did not match. Usually first name, last four of social security, and date of birth. Or wrong terminal designation. It shouldn't be a terminal diagnosis. So you can amend or cancel a certification before it is linked by the patient. You will see this in your dashboard. The certification is, the status is eligible. You can still amend that and you can cancel that. But once it is linked, the status will be active and you can only revoke the certification, and revocation revokes the whole application. So the minor diagnosis need to match, and they need to have a recommending and a reviewing certification. And the type of certifications, some will submit an OAPP certification for a regular MCPP application, so they don't link again. For the waivers, most denials are due to inadequate justification for the waiver amount requested. If it's too high, you have to provide a lot more compelling justification. And so the last one is, with the new system, HCPs can now update their own information in our system. Just please note that if you are changing your email, this is the username that you use with Okta. You will need to contact Okta if you're changing your email, because we IDPH do not have access to make changes to Okta. So that's all I have. If there are any questions, thank you.
Thank you to our wonderful speaker. We do have a couple of questions. I wonder if, Jeanette, there was a question that Dr. Mendoza-Temple attempted to answer as well, but can you discuss more what a valid patient-physician relationship, specifically how long of a relationship is needed? And Dr. Mendoza-Temple put in here, she has not seen specific parameters, but or in our regulatory requirements, it is not spelled out, but she generally requires her patients to see her every 6 months and then yearly at a minimum, because she doesn't have the capacity to see them every 3 months, which might be ideal if I'm paraphrasing you there. Do you
Correct.
have anything else you can add to that, Jeanette, as to what we at IDPH look at for when someone is being certified by their physician?
We don't have like a written down or specific definition for bona fide relationship. However, we do have a little bit more like it's more of a high level of suspicion if there is, because ideally, if you're recommending medical cannabis, you will be able to follow up with the patient if there is issues, after when they start using it. If it's based basically on patients' complaints and other complaints, and so we do follow up on that, and we do report them to IDFPR if we have a high level of suspicion, in terms of they don't really have a bona fide relationship and they're just doing that for actually in our uh, in in the rules, there is some sort of a definition of a bona fide relationship, but it is very hard to enforce or like really look into. But I can share that. I'll paste it in the comment section
Okay.
of what
That
it's.
sounds great. And I think the standards that Dr. Mendoza-Temple laid out sound pretty reasonable to me. I want to mention again that the slides and the recording will be sent to all of the attendees. And let's see if there were any other questions. I think Jeanette went over the procedures in depth for how to become certified and what the healthcare professionals need to do. And then let's see what else there might be here. I'm just scrolling through the questions. Da, da, da.
There are a few
And,
coming in now. Yeah.
oh, okay, good. You dropped in a few articles as links here, and I think those links, are they included in your presentation as well?
Not the link, but Dr. Lynn had asked, like, what were those RCTs, the 5 that I mentioned that showed that cannabis can help neuropathic and fibro. I did put the PDF in there so you can look at like how good were those studies and follow Dr. Cunard's recommendation to evaluate that yourself. Then there are questions that came up about information about cannabis resistance on pain after prolonged use. And I do see patients where something works for a while and then it stops working. And I hear them tell that story too about, hey, I tried gabapentin for a while. It worked initially and now it doesn't. And I have to move the dose up. For those patients, I find that they have a history of having to rotate things work and don't, including acupuncture, massage. They just, something about their systems, they sort of fatigue of a treatment. It doesn't work. I have them rotate through, use your cannabis, and then when it stops working, take a break, let your receptors refresh, try something else, and come back to it in a month. This is how we are, the art of medicine. You have to kind of go with that individual. I have other patients who are on the same exact dose of whatever they're taking since 2015 when the cannabis program started. And I'm like, you are lucky. That's great. So it is that's why seeing your patient regularly is important. Hence the bona fide patient relationship. And I do have a commentary about the places where they certify. There are physician clinics where they certify patient once and the patient never comes back. And that part, I don't know how to address that because is that a real relationship? Are the patients coming back to talk to them about cannabis? And that's why I really want our mainstream physicians, the ones who are seeing your patients all the time. You should know about this so your patient can come back to you and you can give very good advice, or at least know where to send folks. And another question coming up with that: do you have to see your provider every 3 years when you renew your card? And that gets obviated by requiring them to come in once a year so that you don't have to worry about that. But I do have a few patients where I certified them. I told them you have to come back in a year. They don't come back. And there was a point where I'm like, I can revoke your licensure if you don't see me. And so they would just come because they were too afraid to lose their license. So there are ways to reinforce that. If you want to keep getting renewed by me, then we need to keep up a real relationship. And that's like with any other good medicine.
I think we can add the links to your PDFs also
Okay.
into your presentation before we send it out to everyone. Another question was, are there any resources to help patients pay for the medical marijuana card? I don't believe so. I'm looking at you, Jeanette. I don't think so. Not that I'm aware of.
There is a reduced fee eligibility for medical cards. So terminals, veterans, terminals are free. Terminal cards, veterans, SSI, SSDI, and some disability retirement, teachers, and I think railroad retirement. So far, those are the only things. So there is a reduced fee for that. They pay about half.
I wish there was a program for people who can't pay for the cannabis itself because it's cash pay only, which is what we're hoping Schedule 3 might change a bit, but that's probably going to help the pharmaceutical side of things. Great question here coming up from Tina Horsky about, I'm not familiar with how cannabis prescription is written, so we're not technically prescribing. We are certifying patients until we can say we're prescribing. It's still illegal to do a prescription, but I will advise patients to start with that 1/4 of an edible of the lowest THC edible that the dispensary has. That's all you really have because the dispensaries carry a rotating stock that they usually have on their websites, but much of the time I don't have time to like look at their menus. And I tell the patient that when you go to the dispensary, tell them you're a new user. I want the lowest amount of THC possible. I'm not interested in being intoxicated. Of course, there are people who are. Just don't get in your car and drive. There are people who are using alcohol and other. I just, in a very non-judgmental but guiding and helpful way, the more THC that you take, the more intoxicated you will be. So a nice beginning is the 1.25 to 2.5 milligram of THC in whatever formula you're getting, and spread it out. Give yourself 1 or 2 hours to feel the full effect before you even decide to take more, so that you know, that's a very nice way to start, or a 20-to-1 CBD to THC ratio if they can find it, and take at bedtime. That would be a very good beginner prescription if we're allowed to say that. And when you bring that idea, I actually have a patient, I print my after visit summary and I say, bring this to the dispensary and just ask them for this. And that makes the patient feel very empowered, and you feel safe that you've also documented, you've recommended low THC. And as the patient has to relay the dose to the dispensary, do they, yeah, you can just say, I want the lowest THC 1.25 to 2.5 milligram. They'll know, because this, usually the edibles come in 10 milligram pieces, but not always. Some of them will have 20 milligrams. So you have to really look at the product and look at the serving size, because a whole package will say 100 mgs of THC. That's in the entire package. So, oh, 10 pieces, that's 10 milligrams of THC. And we need labeling to be much clearer. Thanks for the question.
Thank you. I don't think I see any other questions. Here's Dr. Rashmi Shuk. How long after their last dose do you advise patients it's safe for them to drive?
Personally, I just prefer them use it at night. Make sure when you wake up in the morning, which hopefully is 7 hours later, it should be petered off. You have to make sure you're completely clear-headed to do it. So everyone has a different metabolism, and it's very hard to make that prediction. So my toxicology colleague, Dr. Lycan, would say, wait 24 hours, which is not realistic, because then you can't ever drive if you use cannabis. It's fuzzy. It's really fuzzy. I don't have a time frame. Some people metabolize cannabis very, very quickly, and they're back on their feet, just like with alcohol. And you probably could use those similar parameters, except alcohol is a little more predictable, because you have breathalyzers. So it's a messy answer, but people also have not the best judgment about themselves. Definitely not within the first 4 hours of using. Definitely not, because you can be fully under the influence, and driving under the influence of cannabis can impair your reaction time, which is bad for driving. Alcohol, I've heard, tends to make people more reckless. They're both bad combinations. But don't forget, people take prescription medications like opioids and benzos. Don't forget about those folks who are also driving under an influence. Sorry for my messy answer.
Oh, perfect. That was absolutely perfect. So, thank you. Thank you both very much. I did just want to clarify, because it seemed there was a little question here. Cannabis is still, as Dr. Mendoza Temple said, illegal at the federal level. It has been legalized in Illinois, but in order to protect our physicians, they don't actually write a prescription. They will go on to the IDPH website and certify that a patient has one of the qualifying conditions. The qualifying, I think there was just a question that went by while I was talking about where are the qualifying conditions. They're published on our website. And so we can, I think the link to where those, the list is on your slides, right, Jeanette?
Yes,
Okay.
yes, I will
If you need the
also
link, it will
right.
be in the slides that we will be sending out to you. Oh, and Jeanette just put those into the chat. So thank you. Let me just, I have a couple of concluding slides here in our last 2 minutes. And let me put those up. Okay. Down to the end here. Sorry for making you dizzy. These are the upcoming Fast Facts presentations. February 19th is going to be Dr. Jen Suh, who's our pediatric medical advisor, and she's going to walk through, or try to walk through, all the different guidance that has been coming our way about vaccines, and what the state of Illinois is recommending. March 19th, we are still formulating that presentation. And then April 19th, I'll be up again, and we'll be giving kind of a smorgasbord about different chronic diseases and programs that IDPH has in the chronic disease section. If you have any questions for the IDPH Medical Services Division, you can go on our website, or else here again, this will be in the slides, is the QR code. You can send us a question. You can ask for a particular presentation that you'd like to have seen, anything you wish. And then again, I want to encourage all of you to sign up for Siren. That's the main way that the Illinois Department of Public Health sends information out to clinicians. Here's a QR code. It's also on our website where you can sign up and you will get pushed notifications for these presentations and also other important information from IDPH. And then here is the QR code for the continuing medical education survey that you need to complete within 7 days. It will, of course, the link will also be in the presentation that we send out to you. And if you have any questions, our administrative assistant, David Hale Arroyo, has his contact information in there. And he put the link to this survey into the chat as well. And that is it. It looks like Dr. Mendoza, did you squeeze in one last question answer here?
Trying to find them all. Yeah, like who pays for the fees? The patient pays the fees, but your insurance pays for the physician visit or the nurse practitioner or the qualified provider.
All right. Well, that concludes our session for today, and thank you all for joining us. And thanks again to our wonderful presenters. We really appreciate you coming and sharing your expertise with us.
Thank you for having me.
Thank you.